All right, we're going to start with palpation of the pelvis and hip area, and we're showing you on the skeletal model first. So the first thing we'll do is find the iliac crests. Those are really easy to find, so we'll come in with the palms of the hands into the soft tissue of the hips, and you should feel a bony end feel here. Then we can turn our hands in this way and come into the sides a little bit, and then come down and land right on the iliac crests. So the iliac crests, if we follow those will lead us down to the ASIS. So if we palpate the iliac crest and work your way down, you should be able to find the anterior superior iliac spine, or the ASIS, and that has a muscle attachment for the sartorius, which we'll talk about in just a few minutes. Out here on the iliac crests, we have the iliac tubercles. These are the widest points laterally on the iliac crest, and they serve as an insertion point for the gluteus medius muscle. If we come back to the ASIS, use the pads of your fingers and go ahead and work your way around the ASIS and kind of feel the bony structure of the ASIS. If we move down about a finger's breadth and in medially about a finger's breadth, we'll run into the AIIS, or the anterior inferior iliac spine, and this serves as the origin for the rectus femoris muscle. So there's a lot of soft tissue here. You have to press deep down in there to get to it, but if you press deep enough, you should run into a bony end feel there. Okay, now we're going to cover the lateral femoral triangle. So the lateral femoral triangle is made up of three muscles, and it forms a triangle at the top of the hip. So again, the easiest way to find this is to palpate the ASIS. Use the palm of the hand and just move in the soft tissue in a circular fashion until you get that bony end feel. That serves as the origin for the sartorius muscle. So the sartorius muscle runs from the ASIS down to the pes anserine region. That forms the medial border of the lateral femoral triangle. So there's one border coming here. If we palpate on the other side, just this posterior side of the ASIS, that's where the origin of the tensor fascial lata muscle sits. And that TFL muscle runs down the lateral thigh and inserts at Gerdy's tubercle down here on the lateral knee, on the lateral tibia. So those two muscles form the borders, or the tip of the triangle, coming into the ASIS right here with the sartorius, and the TFL right here. So there's actually no bottom to the triangle. It's more like an arrowhead coming up here. And in the floor of the triangle, we have the rectus femoris muscle. So that originates on the AIIS, the anterior inferior iliac spine, and runs down the femur all the way to the patella. So that's the lateral femoral triangle. Okay, next we have the iliopsoas muscle. So that's a combination of the psoas major and the iliacus muscle. So the psoas major comes off the spine, and the iliacus muscle comes off the iliac fossa here. They converge together to form a common tendon that inserts onto the lesser trochanter. And you can palpate that. Here's your inguinal ligament here. So you can palpate that over the top of the inguinal ligament or underneath the inguinal ligament. If you push deep into the soft tissues and then have the patient gently flex the hip, you can feel that muscle contract under your hand. Okay, we also have the anterior acetabulum and the femoral head right here. This is a very deep set structure, and it's hard to get any detail on this palpation because there's so many soft tissues overlying this. So when I palpate this, it's usually because somebody has anterior hip pain, and I'm suspecting that there's pain or pathology in the hip joint itself. So again, if we locate the ASIS and locate the pubic tubercles, these make a nice little triangle with the femoral head right there. So you can kind of visualize that little triangle between these. If I palpate down through the soft tissues just under the inguinal ligament right here and just below the AIIS, you'll feel a nice bony end feel right here. But understand, you're pushing through a lot of soft tissue to get here. So we're pushing through the iliopsoas muscle, we have the pectineus muscle right here, we have the rectus femoris muscle right here, and then we have the joint capsule and all the hip ligaments overlying that. So you're not going to feel detailed bony palpation, but if you palpate down here, you kind of get a sense of this rounded structure right here, and you can kind of palpate into the soft tissues all the way around it and feel this nice bony structure right here. Okay, we've also got the superior pubic ramus. So that's the top of the pubic bone right here. And that serves as the origin for the pectineus muscle running running laterally to the medial femur. And then we have the pubic tubercles right here. So the way I like to locate this is to start just above the umbilicus and work your way down with the heel of your hand until you run into a bony structure. So keeping the fingers superiorly is a little more comfortable for the patient most of the time. And then once I locate that, then I'll use my other hand and come in with my finger pads and locate those pubic tubercles. So those pubic tubercles are the most anterior projections of the pubic ramus, and then the pubic ramus runs laterally, and that's all palpable along there. The pubic tubercles also serve as the origin for the adductor longus muscle, running from the pubic tubercles to the medial femur here. Now we'll cover the medial femoral triangle, and the medial femoral triangle contains a lot of the neurovasculature that runs down the thigh. So we'll go ahead and palpate that now. So the first thing we want to do is recognize the three borders of the medial femoral triangle. One being the inguinal ligament running from the ASIS, which we've already palpated, to the pubic tubercle, which we've already palpated. So if you can palpate those two structures, then you can find the inguinal ligament running between those. You want to palpate that in a transverse fashion across the abdomen right there, and it should feel like a firm ropey structure running from ASIS to pubic tubercles. We've also talked about the sartorius. That forms the lateral border of the medial femoral triangle running from ASIS to pes anserine this way. And then the adductor longus muscle running from the pubic tubercles to the medial femur. Those three form that triangle right there. So the easiest way to activate and fill the contents of the medial femoral triangle is to get the patient in this position with the knee flexed and the hip in some adduction. Have the patient adduct the hip against some pressure here from the therapist, and then that should allow that adductor longus muscle to contract. So this adductor longus muscle in this position is extremely easy to palpate. So if you have the patient adduct, you should be able to feel that adductor longus muscle. It feels like a large round muscle running from that pubic tubercle to the medial femur. You should be able to palpate it right there. Once you've palpated that, you can drop laterally into that medial femoral triangle, and you should be able to feel the border of that sartorius right there and that adductor longus converging. So find the adductor longus, roll over the top of it, and you should feel that sartorius muscle. Then you can work your way superiorly and feel the contents of the triangle, which is the femoral artery, nerve, and vein. So the nerve is most lateral. It feels like a ropey structure. You can palpate that transversely going through the medial femoral triangle. Then we've got the artery. You should be able to press deeply and feel a pulse. The way I like to do it is to press deeply and then slowly let off pressure until I feel that pulse under my finger. And then the vein is usually not palpable. Okay, and then we've also got pectineus, again running from the superior ramus of the pubis to the medial thigh here, the medial femur, and that forms the floor of the medial femoral triangle. Okay, next we have the gracilis muscle. This is an adductor muscle. It's the most medial muscle of the thigh, and it runs from the pubic ramus down to the pes anserine area. So the way I like to activate and palpate this muscle is to put the patient in this position again, where they can perform some active adduction of the hip, and that should make that muscle activate. So the easiest way for me to find this muscle is to first locate that larger adductor longus muscle by having the patient adduct the thigh. And as they adduct and I palpate that larger adductor longus muscle, if I roll medially and posteriorly over the top of that muscle, I should be bumping into the border of the gracilis, and you can feel the demarcation between those muscles. If I really want to activate the gracilis, it is an adductor, so this motion will activate it, but if you add some knee flexion with that, that'll really activate that gracilis, and you should be able to palpate that. It's a longer and more ropey structure than the adductor longus. Okay, and we've also got the lateral femoral cutaneous nerve. Don't panic if you can't palpate this one. It's an extremely tiny structure that runs out of the anterior hip. So if you can palpate the ASIS and we have the inguinal ligament coming this way and the sartorius coming this way, usually that lateral femoral cutaneous nerve runs just under the ASIS and comes superficially out onto the thigh and innervates the skin on the lateral thigh. So if you come up here under the ASIS and just palpate in a transverse fashion right here, sometimes you can feel your finger running over the top of that little tiny nerve. Okay, next we have some lateral palpation of the hip and pelvis area. So the easiest place to start right here is by locating the greater trochanter. So the greater trochanter should be the most lateral portion of the hip if a patient is in a side-lying position. So just come down with the palm of your hand and gently locate that greater trochanter by moving your palm in a circular fashion, and you should be able to get an idea of the size and the shape of that bone. Once you've got it with the palm of your hand, then go ahead and locate it with the finger pads, and you can work your way around it, locating the details of that bony structure. Next we have the gluteus medius and gluteus minimus muscles. The gluteus medius and minimus, they come off the ilia here and they attach into the greater trochanter here. So again, we'll have to locate the border of the iliac crest here. And if you've located the border of the iliac crest by default, it's easy to locate the gluteus medius muscle by coming inferiorly. So if I come off the iliac crest inferiorly, I should be right on that gluteus medius muscle, and that gluteus minimus muscle sits right under that gluteus medius muscle right here. So if you have the patient abduct the hip here, you should be able to feel that muscle contract under your fingers here. And that should also allow you to feel the greater trochanter by having them laterally rotate the hip here. That greater trochanter should move under your hand and under your finger so you can be sure you're on that muscle. We've also got a trochanteric bursa right here, and that usually sits just behind the greater trochanter right here. And again, bursa are structures that allow frictionless or minimize friction from tendons and structures that glide over the top of each other. So some patients will come in with pain right in this area, and they can come in with trochanteric bursitis. We've also got the insertion point on the back of the hip here for a lot of the hip external rotators. So we have the piriformis right here coming off the anterior surface of the sacrum and inserting into the back of the greater trochanter. We've also got the gemellus superior and inferior, and the obturator internus and externus right here, and the quadratus femoris all coming in from the posterior hip and inserting on the back of this greater trochanter. So you'll see a lot of issues with patients on the back of this greater trochanter by palpating those tendons there. Okay, now we're going to palpate the patient in a prone position. So we're going to start again where we started anteriorly, and this is with the iliac crests. So you can come in to the flanks of the patient and then come down on top of the iliac crests, and just like we did anteriorly, you can work your way posteriorly until you run into the PSIS. So once you've located those PSISs, go ahead and use your finger pads and see if you can locate the details of the PSIS. And this is a nice structure posteriorly to find, because it's one of those large structures that will help us find other structures. Once you've located the PSIS, in most individuals, the PSIS sits at about the level of S2. So if I draw an imaginary line between these two PSISs, or posterior superior iliac spines, notice how they sit right about the level of S2 here. So now I know I'm on S2 of the sacrum, and I can work my way down the sacrum until I run into the sacral hiatus. So the sacral hiatus is an area where the lamina didn't fully form in the sacrum like they did in other parts of the spine right here. And it usually has a connective tissue membrane covering it, but you can usually feel that sort of broad flat area of the sacral hiatus right here. If I drop just below the sacral hiatus, and this is about level S4 and S5, if I drop just below the sacral hiatus, you should be able to feel a little joint line running right here between the sacrum and the coccyx, forming the sacrococcygeal joint. So use a finger and palpate that and see if you can feel that little transverse line right there. If you go down further and put some pressure on the coccyx, you should actually feel the coccyx move, And this joint actually has quite a bit of movement right here. So you can come down with palpation and push on that coccyx and move that sacrococcygeal joint. Okay, if I come just up or just lateral to that sacral hiatus, I should be running into the inferior lateral angles of the sacrum. And this is the area where the sacrum runs from superior to inferior and then goes medially. So it's this little border right here where the sacrum takes a turn. And that's an important structure because we'll find some other structures off that. Moving forward, we have the long posterior sacroiliac ligament. So this is a ligament that runs from this inferior lateral angle, or this ILA of the sacrum, and runs to the PSIS posteriorly. So we have the PSIS, we have the ILA, and a big broad flat ligament that runs between these two. It's really difficult to feel the details of this ligament because it does fan out and it is very thick and broad, so it almost just feels like bone if you put pressure in that area. But if you can locate these two areas, then usually you know where that ligament runs. Okay, a few more structures right here. If we find the PSIS again, locate those with the palms of your hands, and then you can come off with your finger pads. Once you've located the PSIS, there's a little indentation right here called the sacral sulcus, and this is really close to the sacroiliac joint. So the SI joint, or the sacroiliac joint, is where the ilium and the sacrum come together to form a joint right there. So if you find the PSIS and come just inferiorly and medially, you'll be right in that area of the sacral sulcus and the sacroiliac joint. Next, we have the largest muscle, one of the largest muscles in the body, the gluteus maximus, and it sits on this lateral border of the sacrum as its origin, and it comes up and onto the iliac crest as well. And then it has its insertion point down on the posterior and lateral femur right here, and it helps to extend and externally rotate the hip. So if you have the patient extend the hip and externally rotate, you should be able to see the orientation of the fibers of that glute max, and it should contract under your hand. Very easy to palpate. We also have the piriformis muscle, which we've mentioned previously. This muscle runs from the sacrum, the anterior border of the sacrum, and it kind of looks like a long triangle going to the posterior greater trochanter right here. So in order to palpate this muscle, it's difficult, especially if the patient is large and has a lot of soft tissue, because we're pushing through the gluteus maximus to get there. However, in a lot of patients, especially those patients that are thinner, a lot of times you can feel some of the details of that piriformis muscle. So if I locate this lateral sacrum and this greater trochanter and kind of draw an imaginary line between the two, and then push through the glute max and palpate superior to inferior like this with your fingers, sometimes you can feel a slight ropey structure underneath that gluteus maximus and roll over the top of that. This piriformis muscle is also important because it lies right next to the sciatic nerve, and sometimes you can get some sciatic nerve symptoms that run down the leg when you push on that or palpate that. Okay, next, we can't see it on this skeletal model, but we have the gluteal fold. The gluteal fold is just the soft tissue crease right here under the gluteus maximus, and that can help us locate one of the bony structures, the ischial tuberosity, which is the sitting bone. So if I locate this gluteal fold and push just straight up into that gluteal fold with the thumbs, sometimes you can run into the bottom of that ischial tuberosity right there. So these are the bones that we sit on, and this also serves as the origin of the hamstring muscles, and it also has a bursa that sits right here for those hamstring tendons. So those three hamstring muscles share this common origin, and then they insert on the medial and lateral, or the medial tibia and the fibula laterally. So next we also have the sacrotuberous ligament. The sacrotuberous ligament comes right off of the ischial tuberosity and runs to the ILA, or the inferior lateral angle of the sacrum. So remember, we have the long posterior sacroiliac ligament coming from the PSIS to the ILA, and we have the sacrotuberous ligament coming from the sacrum, coming from the sacrum to the ischial tuberosity. So sacrotuberous ligament and this long posterior sacroiliac ligament. Okay, we also have the sciatic notch. So the sciatic notch is just an indentation where the sciatic nerve runs down out of the pelvis and down into the thigh. So if we locate this ischial tuberosity right here, and we locate the greater trochanter right here, you can kind of see this indentation right here where the sciatic nerve comes right out of this sciatic notch right here and runs down, runs down through the sciatic notch right here between the ischial tuberosity and the greater trochanter. All right, so the first thing we're going to cover on the surface is the iliac crest. So if we come in from the lateral sides on both sides, you should be able to feel those iliac crests, and you can feel the ridges of them right there. If we come in and flank the patient like this, come into the flanks and then come down on, we can come on top of the iliac crests. Then we can follow them anteriorly all the way till we get to the ASISs right there. So once you get to the ASISs, another way to find those is to use the palms of your hands and kind of eyeball those and come anteriorly and drop right onto the ASIS. Once you're there, you can use your finger pads to locate the details of the ASIS. And remember, that's the origin for the sartorius muscle. Out here laterally, we also have the iliac tubercles. So that's the widest portion of the pelvis laterally. And just under the lip of the iliac tubercles, we have the origin point for the gluteus medius, which we'll cover in just a few minutes here. So if we go back to the ASISs, we can locate the AIIS, or the anterior inferior iliac spine, by dropping under the ASIS here and then moving just medially, and we can push down into those into that soft tissue space there, and you should be able to get a bony end fill. That's the AIIS, and that serves as the origin for the rectus femoris muscle. Okay, next we'll locate the lateral femoral triangle. So the lateral femoral triangle is a convergence of two different muscles that form a point right here. So if we find the ASIS right here, we know the sartorius muscle runs this way and runs all the way down and it inserts on the pes anserine region of the tibia here. So there's your sartorius muscle. And then we have the tensor fasciae lata muscle just behind the ASIS. So if we locate the ASIS, we can find the origin of the sartorius, and just behind it, the origin of the tensor fasciae lata, or the TFL muscle. So the convergence of those two right there is the tip of the lateral femoral triangle. And then the floor of the femoral triangle, of the lateral femoral triangle, is the rectus femoris. So if we find the AIIS again right there, the rectus femoris comes down the medial thigh all the way to the patella right here, and that's the lateral femoral triangle. We can also locate the iliopsoas with its bursa. So if we locate the iliac crest right here and come in right there, we can actually take our fingers and roll just around that iliac crest and push down into that iliac fossa and feel that iliacus muscle right here. So that iliacus muscle converges with the psoas muscle, and they run under the inguinal ligament to the lesser trochanter of the femur. So if I push down right here and then have the patient just gently raise the leg up off the table into hip flexion, I can actually feel that muscle contract under my fingers there. So that's the iliacus muscle, and that has a bursa that's associated with it right there as well. Okay, next we have the anterior femoral head and the acetabulum. So one good way to find this is to locate the iliac tubercles. So if I take the palm of my hand and just come under the umbilicus and work my way down, and this is a good time to get informed consent from your patient, but if I work my way down, I can feel that pubic bone right there, and the anterior projections off of that bone are the pubic tubercles. So here's the pubic tubercle right here, here's the ASIS right here, and between that is the inguinal ligament. And if I come down just under the inguinal ligament, I can palpate in this soft tissue space, and I'll actually feel a hard end fill right there. So that femur is coming up right here, and the neck and head of the femur turn this way, and the acetabulum and the head of the femur are about right here. So here's my ASIS, here's my my pubic tubercle, and here's the femoral head. It forms this nice little triangle right here. So I can push down deep and get that hard end fill of that anterior femoral head and acetabulum. Okay, we're going to go again to the pubic tubercles. So if I work my way down from the umbilicus all the way down into where I locate that pubic bone, there's the pubic tubercles, and the pubic ramus runs laterally. So I can work my way laterally off that from those pubic tubercles on top of that pubic ramus. So the medial femoral triangle is created by the border of three structures. One is the inguinal ligament running from the ASIS to the pubic tubercles. One of them is the sartorius muscle running from the ASIS down to the pes anserine area down the leg here. So there's one border, there's two borders, and then the last border is the adductor longus coming off of that pubic ramus right here, or those pubic tubercles right here, and running down to the medial thigh. So that creates this triangle right here called the medial femoral triangle. To palpate that, the best way to palpate the medial femoral triangle is to get the patient in this position and then have them lift their leg this way against some resistance, and you'll see that adductor longus muscle contract. So you can see the adductor longus muscle. It's a very big muscle that runs down into the medial thigh right here. So relax, and you can see it contract again right there. So there it is. I can palpate that transversely going across here. And if I roll to the back side of this, that runs into the border of the sartorius muscle coming from the ASIS and heading toward that pes anserine right here. So it runs straight this way. Contract one more time for me. So there's adductor longus, there's sartorius, and they converge right there to form the bottom of that triangle. Once I've located that, I can work my way up. Move short, there we go. I can work my way up and palpate down in that triangle right there, and I can feel his femoral pulse right there. So from lateral to medial, we have the femoral nerve, the femoral artery, and then the femoral vein. So I can feel the femoral artery, the pulse from the femoral artery right there, and then I can move laterally and palpate transversely across that femoral nerve, and that can be difficult to locate. You might have to do a little bit of looking in there to try to find that. Okay, and then in the bottom of the triangle, I'll land right on top of the pectineus, and that lies right underneath the neurovasculature right there. Okay, and lastly, we have the gracilis muscle. It's the most medial muscle on the medial thigh right here. The easiest way to find gracilis is to have them adduct the thigh again. Go ahead and contract against resistance. You can see the muscle belly of the adductor longus right here. So if I roll over the top of the adductor longus, I'm running into the border of the gracilis right here. So here's the gracilis muscle running down. Remember, it runs all the way to that pes anserine, and just above that is the adductor longus muscle. So roll over the top of the adductor longus and you'll be in the border of the adductor longus and the gracilis right there, all the way down. So now we'll palpate in a sideline position. We're going to start with the greater trochanter. If you just place your hand on the most lateral portion of the hip that you see sticking up, then you'll likely be right over the top of the greater trochanter. So go ahead and locate the greater trochanter with the palm of your hand. Then you can locate the details of the greater trochanter with the finger pads and work your way all the way around that. Okay, we also have the iliac crest up here, or the gluteus medius that comes off of the border of the iliac crest. So we're going to come down on top of the iliac crest again, and you can work your way all the way over until you find the ASIS, which is right there. Here's my greater trochanter, and here's my iliac crest coming around. So if I get up on top of the iliac crest and then just come down about halfway to the greater trochanter and have the patient abduct the hip, abduct, good. Then that activates that gluteus medius muscle. It's a hip abductor, and that muscle belly should contract into your fingers. Go ahead and one more time. Yep, good. So the gluteus medius muscle sits right there. The gluteus minimus sits right underneath it. If we come back to the back of this greater trochanter, one common thing that you'll see in the clinic is trochanteric bursa, which is inflammation of a little bursa that sits back here on the posterior side of the greater trochanter. So you can locate that posterior greater trochanter and palpate in and ask the patient if they have any symptoms and assess for any issues back there from that bursa. And then we also have the insertion of the small posterior hip muscles. Most of these are lateral rotators, so we have the piriformis running from the back of the greater trochanter to the sacrum. And then we also have the gemella superior and inferior, the obturator internus and externus, and the quadratus femoris that all insert into that greater trochanter. All right, from a prone position, we can locate a lot of structures in the posterior pelvis and hip. So we're going to start where we started anteriorly with the iliac crests. Come in from the sides and locate the iliac crest with the palms of your hands. Then you can roll up on top of those iliac crests in the flanks and drop down on top of the iliac crests. And then move posteriorly all the way until you get to the posterior superior iliac spine, or the PSIS. So those are located right there. Now you can use the finger pads to really get the details of the PSIS. Once I've landed on the PSIS, if I draw an imaginary line between those two, I'll be over S2 on the body of the sacrum. So once I'm at S2, then I can work my way down to other sacral levels. So we're going to pull down to about right there. So let me locate the PSIS again. So here's the PSIS. There's S2, which means S3 would be about right there, and S4 is about right there. S4 and S5 have the sacral hiatus. So the sacral hiatus is that portion of the sacrum where the lamina failed to fuse, and there's a little portion, a little flat portion that's covered by a membrane. Okay, if I go just below that sacral hiatus, you'll be right at the natal cleft right there, and you can actually feel the sacrococcygeal joint. So I'm at the very bottom of the sacrum, and down here is the coccyx. Okay, if we go back down to the sacrum here, here's the PSIS, here's S2. I can come in laterally at about the level of S4 is that inferior lateral angle of the sacrum. So if I come down to about S4, I'm expecting the inferior lateral angle to be about right here somewhere. So I can come out in the soft tissue of the hip and come in this direction, and I can feel where that sacrum starts to take a turn right there. So here's the lateral border of the sacrum, and now it starts to take a turn and go medially right there. So there's the inferior lateral angle of the sacrum. And that's important because if we find the ILA, or the inferior lateral angle, we can also find that long posterior sacroiliac ligament. So again, if I palpate for the PSIS, that's located right there. Here's the inferior lateral angle of the sacrum. There's a very big, broad ligament that runs down from the PSIS to the ILA, forming the long posterior sacroiliac ligament. We can also take a look at the sacral sulcus and the sacroiliac joint right here. So again, if we go back to that PSIS, those are located right there. And if I move just medially and inferiorly, there's a little dip right there in the soft tissue. And that's where the sacral sulcus is formed. So there's a space on the anterior side of that PSIS where the sacral sulcus is located, and the SI joint is very close to that too. So just come inferiorly just a little bit and medially, and you'll feel that sacral sulcus, and you'll be right over the top of the SI joint. Okay, lastly we have the gluteus maximus. So the gluteus maximus runs on the lateral border of the sacrum all the way up and around the iliac crest right here, about halfway up the iliac crest. And the fibers are oriented diagonally, and they insert on the lateral border of the femur. So go ahead and extend your leg for me. You can see the mass of the gluteus maximus, and you can see its fiber orientation as it comes down this way from the bottom of the sacrum all the way up the iliac crest down this way. So go ahead and extend one more time. Go ahead and palpate that gluteus maximus and get an idea. You can actually follow its borders all the way up that iliac crest and all the way down that sacrum. Next we have the piriformis. So the piriformis comes off the anterior body of the sacrum and attaches on the greater trochanter. So I'm going to do it on this side over here. If I find the greater trochanter with the palm of my hand, there's the greater trochanter. I can also find the lateral border of that sacrum right there, and I can feel where it starts to take a turn right there. So there's the lateral border. If I draw an imaginary line between those two, I've found the the piriformis muscle. So once I've got that little line, I can palpate deeply into the gluteus over the top of that line. And for patients with a lot of soft tissue or muscle tissue, it's extremely hard to palpate the piriformis. But if you have a patient that's very thin, a lot of times you can feel that piriformis as it runs under the gluteus if you're palpating superior to inferior like this. A lot of times patients will have painful symptoms here too, or even symptoms of sciatic nerve, the sciatic nerve distribution. So they may feel something down in the thigh or down in the leg with that. Okay. Next thing we're going to do is locate the gluteal fold. So the purpose of this anatomical structure is just to help us get a good landmark to locate other structures. So go ahead and extend your hip for me. So you can see the gluteal fold forms right there, and that's about the spot where I use to locate the ischial tuberosities. So if I take my thumb here and push straight up into the gluteal fold, I'll run into that ischial tuberosity right there, and I can locate those on both sides. So the ischial tuberosities are the sitting bones, and that also serves as the origin of the hamstring muscles. Okay, it's also got a bursa that sits over the top of those hamstring muscles as well to reduce friction there. Okay, so the hamstrings share a common origin right off of that ischial tuberosity. And then we can also locate another structure off the ischial tuberosity called the sacrotuberous ligament. So if we locate that ischial tuberosity and we locate that inferior lateral angle of the sacrum again, so if I push in this way and locate that inferior lateral angle of the sacrum, there's a very broad ligament that runs from the ischial tuberosity all the way up to that inferior lateral angle of the sacrum. So if I come off of the ischial tuberosity now and just work my way up medially and superiorly all the way toward that sacrum, there's a you have to palpate deep, but you can feel that ligament as it works its way up. It almost gives you a hard end feel like a bone. So if you feel like you're feeling a bone in there, it's probably that sacrotuberous ligament coming from the sacrum to the ischial tuberosity. Okay, the next one is the sciatic notch. The sciatic notch is formed by the ischial tuberosity and the greater trochanter, and it houses the sciatic nerve as it runs down the leg. So again, if we locate that ischial tuberosity up there, and we locate that greater trochanter right there, between those two, I can palpate transversely between those two, and deeply, and that sciatic nerve runs right down in that distribution right there. Okay, next we've got structures of the knee that we're going to look at. So the easiest structure to find is the patella, and if you can find the patella, then you can locate a bunch of other structures here. So go ahead and use the palm of your hand and feel the edges of the patella, then come off with your finger pads and locate that patella, and you can work your way down the borders of the patella all the way to that apex there, and there's the apex of the patella right there, and it forms the patellar ligament. A lot of people call it the patella tendon, but it's a ligament because it runs from bone to bone. It runs to this tibial tuberosity. So the tibial tuberosity is this outcrop of bone right here on the anterior tibia. You can go ahead and locate that, and then go ahead and have the patient extend the knee, and you can feel that patellar ligament tighten up between the patella and that tibial tuberosity. Okay, we're going to go into the medial joint line now. If I locate that lateral border of the patella, if I locate this medial border of the patella and work my way toward the apex, then I can come off medially right here in this soft tissue space. So notice how far I can dive into that soft tissue space. And that's how I know I'm in the medial joint line right here. So once we're in the joint line, I can locate the tibial plateau, this medial tibial plateau right here. I'm kind of sitting on top of the tibia, and I can also do the same thing on the femur. I can feel the bottom of that femoral condyle, that medial femoral condyle. And that condyle is the articulating surface of the knee joint right here. So this medial femoral condyle and this tibial plateau articulate with each other. So I can now work my way medially through this joint line. And what you'll notice as you do that is the tibial plateau and this femoral condyle, the further medial we get, the more they converge. And so I can stay on this tibial plateau and just work my way medially, and then I start to feel them converge. And as soon as they kick me out of the joint line, so right there is the last I feel of the joint line, and right here I feel like it kind of kicks me out of the joint line. So this spot right here where it kicks you out of the joint line is the medial collateral ligament, or the MCL, and that runs all the way down into the pes anserine and all the way up into this medial epicondyle. So to palpate the medial epicondyle, you can come in from lateral and medial, and the medial epicondyle is the portion of the distal femur right here that is the most medial. So you can feel that and then locate it with your finger pads right here. If I run up under this quadricep muscle right here, go ahead and extend your knee right there. So there's the vastus medialis right here. Okay, relax. If I run underneath that vastus medialis and just superior to that medial epicondyle, I'll land right on the adductor tubercle. So the adductor tubercle is this outcrop of bone right here, and it really dives in deep right there, and it serves as the insertion point for the adductor magnus muscle. So if he adducts his hip right here, then I can feel that tendon contract, and I can feel that tendon as it comes into the adductor tubercle. Okay, going back to the medial joint line right here, we have the medial meniscus. So if you find the joint line and just palpate straight in, you'll be right over the top of the medial meniscus. To make that medial meniscus more prominent, I'm going to have the patient, or I'm going to passively internally or medially rotate the knee, and that will turn the tibia this way, and those menisci will stay with those femoral condyles, and you can palpate it with the femoral condyles right there. So medial rotation helps to bring out the medial meniscus, and we'll do the same thing with lateral rotation for the lateral meniscus. So the pes anserine, if you follow this tibia, you'll notice this tibia has a flat surface all the way from the medial malleolus all the way up to where it flares out. So there's no muscle attachment right here on this tibial crest right here. So as this tibial crest comes up, you'll notice the tibia starts to flare out at the top, and just before it flares out, there's a little region right here that's kind of scalloped out, and it's got three tendons coming in. It's got the sartorius, it's got the gracilis, and it's got the semitendinosus tendon that attach right here. Underneath those tendons is a pes anserine bursa, and this is very tender in a lot of people, even if they don't have pathology. And then underneath that is your MCL. So the MCL is deepest, then the pes anserine bursa, and then those three tendons, sartorius, gracilis, semitendinosus. I can actually follow the semitendinosus all the way down to its insertion. Go ahead and pull your leg back into flexion, your knee back into flexion, and scoot out for me just a little bit if you would. With him contracting into flexion, I can see and feel that semimembranosus right here and the semitendinosus just superficial to that. If I follow that semitendinosus tendon, I can actually follow that all the way in to the posterior and then into the medial tibia and into that pes anserine area right there. Up here on the medial part of the knee, we have the saphenous nerve that runs down the leg right here. There's a branch called the infrapatellar saphenous nerve. Sometimes you can feel that nerve as it crosses over the tibia right here and over the femur right here if you roll up and down. It's a very small nerve, so sometimes it's difficult to locate, but if you work your way around the knee joint right here, close to the joint line, you may be able to feel that infrapatellar branch of the saphenous nerve. Okay, if we come back up here on the femur, next to the patella right here, we'll have the trochlear groove. So if he's in a lot of flexion right here, that patella, the more flexion he gets into, that patella drops inferiorly, and you can actually feel the medial borders of that trochlear groove right there. Okay, and then I'm going to have him contract his quads right here. So we have the vastus lateralis muscle right here, we have the vastus medialis muscle right here, and then we have the rectus femoris superficially, and deep to the rectus femoris, we have the vastus intermedius. All of those converge right here to form the quad tendon, and that attaches to the patella and down to the tibial tuberosity. So you can see the borders of the quad tendon right here as he contracts. Now go ahead and relax. Okay, and it disappears. Now contract one more time. So his patella is right here, and here's his quad tendon right there. And you can palpate all those borders. Okay, if we work our way down this way again, let's put the patient back into flexion. Now this right here, you can see there's an outcrop of bone right here. That's the lateral edge of the femoral condyle. The patella is sunk down right here, so we have this medial and this lateral edge of the trochlear groove, and that's where the patella is able to move up and down. So this sometimes can feel like a patella because it's large, but that's actually a portion of the femur, and that forms that lateral portion of that groove, that trochlear groove. Okay, just like we located the medial epicondyle, we're going to locate the lateral femoral epicondyle. So use the palm of the hand. The most lateral outcrop of bone is the epicondyle, and it sits right above the femoral condyles, which are the articulating surfaces of the joint there. Okay, so we've also got the lateral epicondyle of the femur here, and it serves as an attachment site for the lateral collateral ligament, or the LCL, also the popliteus, and we've also got the IT band running right past the lateral epicondyle toward Gerdy's tubercle here. So next we're going to locate the fibular head. So the fibular head is located just distal to that lateral epicondyle, so follow it distally, and it's located right here. So if I use the palm of the hand right here, I can really get a feeling of the details if I use the palm of my hand, and then I can come off with my finger pads and really get an idea of the shape and size of that fibular head. So just below the fibular head, right here, coursing from the back of the knee toward the anterior leg, is the fibular nerve. So if you found the fibular head right here, go ahead and come under the fibular head, and you can actually see that nerve flipping right there underneath my finger. That's the fibular nerve as it crosses the fibular head right there. Okay. Next, we've got the lateral collateral ligament. So here's our epicondyle, and here's our fibular head. The best way to make this come out is to have the patient cross their leg, and here's that epicondyle, and here's that fibular head, and I can locate that LCL, or that lateral collateral ligament, running between those two structures right there. It's a very tight and ropey structure. Okay, and next we've got Gerdy's tubercle. So Gerdy's tubercle sits on the tibia. So we have our tibial tubercle right here, or our tibial tuberosity. We've got our fibular head right there, and right there is Gerdy's tubercle. So it forms a little triangle with these other structures. So tibial tuberosity, fibular head, and Gerdy's tubercle. Gerdy's tubercle serves as the insertion point for the iliotibial band as it comes from the TFL further up on the hip. Go ahead and extend your knee there. You can see the IT band coming down right here and attaching into Gerdy's tubercle right there. So you can follow that IT band all the way up and all the way down to Gerdy's tubercle. Okay, next we have the lateral joint line. So if we feel the lateral borders of the patella toward the apex, then come off laterally, you should be able to feel that lateral joint line right there, and you should be able to sink your finger into it pretty deep right there. So there's the lateral joint line. Just like we did on the medial side, I can work my way laterally, feeling the tibial plateau and the femoral condyle superiorly until those converge right there. And if I wanted to palpate the lateral meniscus, I would push into that lateral joint line and laterally rotate the patient's leg, and that would make the tibia move posteriorly, and those menisci would sit with the condyles, and I would be able to feel that a little bit better right there. Okay, from a posterior position, remember we have the hamstrings coming off the ischial tuberosity and coming all the way down the leg. If I have the patient flex the knee, you can see those hamstrings popping out at you. So if he just holds against gravity here, I can see semitendinosus right there, and I can palpate that tendon, remember that's the tendon that we followed all the way into the pes anserine, and I can keep following that if I want all the way into that medial tibia into the pes anserine. I can also follow the muscle belly up the leg. The closer you get to the ischial tuberosity, the harder it becomes to follow these and differentiate between these muscles. Just deep to the semitendinosus is the semimembranosus. So I've got a hold of the tendon right there. You can see me kind of flipping it underneath my finger, but that sits just lateral and just deep to the semitendinosus tendon and shares the same origin. And then lastly, we have the biceps femoris. It has both a long and a short head, but we're going to palpate the long head here. It's a very broad and thick tendon that runs all the way down the back of the thigh and crosses the knee joint and inserts right at the fibular head. So you can see that tendon heading toward the fibular head right there. Okay, again, here's the semitendinosus tendon and the biceps femoris tendon. Just inside of those, we have the heads of the gastrocs that dive in deep to the back of the femur, and they originate just above the condyles of the femur. So I'm going to have the patient plantar flex here and activate those gastroc muscles. So here's the lateral head of the gastroc right here. Here's the medial head of the gastroc right here, and you can see they cross the knee joint right here, and they dive in on the insides of those hamstring tendons. So bring it right here to go ahead and plantar flex again. Notice how it's diving. Here's biceps femoris, here's semitendinosus. Those heads of the gastrocs dive medial to, or dive inside of those tendons, and they insert on the back of the femur there. Okay, in this position, we have the gastroc heads and the hamstrings that come down, and they form a little space right here called the popliteal fossa. So the popliteal fossa houses some neurovasculature. We have the sciatic nerve splitting just above here into the tibial nerve and the common fibular nerve, and we also have the popliteal artery running through this space. So we can palpate for the popliteal artery by pushing deep into this space, and I feel it right just lateral to midline right there. I get a nice pulse from him. Okay, we can also find the posterior joint capsule back here. Most of the time it's not palpable unless there's some sort of pathology like a Baker cyst, where we have where that joint capsule swells up and creates a little fluid-filled pocket right there.